Coming to the next bone disorder known as osteomyelitis, it is usually a disorder of the infection which is being caused by infectious microorganisms. So it is known as osteomyelitis. We also see certain necrotic changes as well as certain inflammatory changes. So it is known as osteomyelitis. Osteo means bone, myel means it involves that of the marrow present within the bone, and itis which is a suffix usually added when a particular location is involved with inflammation. So it is an infection which involves the bone, and most commonly it is caused by certain microorganisms which cause systemic infections rather than local infections, which may spread from the systematic areas to that of the bone. And among them, the most common species, it is a Staphylococcus aureus which is involved. Other than that, followed by Staphylococcus aureus, it is the Streptococci, then the Escherichia coli, Pseudomonas, Echinella, Klebsiella. These are certain microorganisms which usually involve in osteomyelitis. So they are usually, we see most commonly we see two type of osteomyelitis. One is a pyogenic osteomyelitis caused by the pyogenic bacteria, and then is a tuberculosis osteomyelitis that is caused by the tubercle bacteria. And usually we see that in such conditions, when it is caused by bacteria, then there's almost a transient bacteria stage, that is a transient bacterial infection which precedes that of the osteomyelitis manifestations. So these are certain changes, what clinical features what we observe in osteomyelitis. Coming to the pyogenic osteomyelitis, usually we see that it is most commonly caused by the Staphylococcus aureus species, and usually it is also seen in syphilis condition also can be seen. It involves mostly the long bones when compared to the other skeletal bones, and most commonly it involves the age group of infancy stage as well as in the young childhood stage, and the infection, it usually spreads by the hematogenous route. It's most commonly predominantly area or the route for spread of the infection to the bone from the systemic region, but otherwise if it could also be because of the direct extension, that is any adjacent area, say suppose the facial areas are being involved with the this bacteria species, they might drain or get infiltrated or being carried through the blood circulation to jaws, and this might result in osteomyelitis of the jaw. So this is why these are the two routes. One is the hematogenous route and the direct extension for the pyogenic osteomyelitis to occur. And clinically we see that these patients, they complain of pain and tenderness at the area of infection. Other than that, we also see certain systemic manifestations such as fever, malaise can also be seen, and the inactivity, patient might also be inactive because of the tenderness. And radiologically, when we observe the findings of this osteomyelitis, we see that the severe bone destruction can be appreciated in these conditions. And the complications, if suppose it is not being treated at the proper time and otherwise being neglected, then it might result in destruction of the bone by the microorganisms, which might at the later stages or consequent stages, it might undergo fractures, and it might also result in gangrene since it's an infection, bacterial infection, and the endotoxins are being released from this bacteria. It might result in gangrenous tissue. And since a body host immune system also has a capacity to fight against this bacteria, and suppose there's any compromised condition of the immune system, this might also result for the allow the growth of the bacteria and result in it leading to osteomyelitis. So immunosuppression can also be one of the reason for osteomyelitis to occur. Other than that, the long-standing osteomyelitis cases being induced by pyogenic bacteria might result in squamous cell carcinoma and amyloidosis or septicemia. So the sequential stages, what we see is firstly the inertia infection. It begins in the metaphyseal end of the bone marrow activity. Since it's a pyogenic bacteria, so these bacteria might result in the formation of pus, and this pus, when it's being extended and it enters into the, or it reaches into the marrow cavity, there will be increase in the tension within the marrow activity. This increased tension might in turn result the pus to be discharged, or otherwise its effect to discharge into the periosteal layer of the bone, thereby causing its inflammation and resulting in periostitis. From the periostitis, we see that is the infection spreads to the subperiosteum, which usually seen surrounding the bone, and this area of the subperiosteum is being replaced, this pus in this area is being replaced by the abscess formation and its associated structures, and is known as granulation tissue. And these abscesses of the granulation tissue, when they are not being properly healed or not being improved in the condition, might result into a draining of the pus through certain sinus tracts from the skin. They drain out through sinus tracts outside into the skin, and this results in progression stage of the pyogenic bacteria. And usually we see that because of the pus cells, as well as also of the continuous activity of the bacteria, there will be destruction of the bone. That is, the bone will be destroyed and necrotic. This necrotic and dead bone is known as involucrum. Upon this dead bone and dead necrotic bone, because of the compromised host activity, this is not being removed by the host immune cells. Because of that, this dead bone, upon this dead bone, since the body also shows its regular physiological and metabolic activity, it will cause in turn the deposition of the normal bone upon it, and this deposition of the normal bone above the necrotic or dead bone is known as sequestrum. This is known as involucrum. This involucrum results as a progressive stage from sequestrum stage, that is from the dead bone to a newly formed bone upon it. Then this involucrum along with the dead bone, this results in a chronic sclerosing non-suppurative osteomyelitis of Gars. So there is a stage progressing from acute stage to a chronic stage. Usually Brody's abscess, it is a condition where we see when it is being involved, resulting into an abscess formation because of this progressive chronic osteomyelitis suppurative disease. Then other than that, we also see vertebrae pyogenic osteomyelitis, where we see that when they are usually involved in the vertebrae region, then this is known as vertebrae pyogenic osteomyelitis. So there is a picture which shows that the osteomyelitis of the tibia of a young child can be seen, which shows numerous abscesses can be seen and in the bone, which appears as a radiolucent areas. Coming to the tuberculous osteomyelitis, usually there is an infection which is spread directly from the lung, or otherwise it could be a pulmonary tuberculosis or the gastrointestinal tuberculosis, which usually reaches to that of the bone or the bone marrow, and subsequently results in tuberculous osteomyelitis. And this is most commonly spread by only hematogenous route, but unlike that of the pyogenic, which also spreads by direct extension. Morphologically, what we observe, since it's a tuberculous granular tuberculosis, that is, it involves caseous necrosis, we can also appreciate the presence of caseous necrosis in this tuberculous osteomyelitis. Other than that, since it's a chronic granulomatous inflammation, tuberculosis is a chronic granulomatous inflammation, we also see granulation tissue formation, and there's also necrotic bone which can be seen. Other than that, progressive stage of this results in draining tracts or some draining sinus tracts, which are known as multiple discharging sinuses. We see that this disease is also known as Pott's disease when it involves the spine, and when this disease extends to that of the psoas muscles, then it is known as psoas abscessus or lumbar caudal abscess. So any long-standing tuberculous osteomyelitis might result into systemic osteomyelitis. There is a complication of tuberculous osteomyelitis. Fibrous dysplasia, it is usually a benign condition, that is, it is an uncommon tumor which usually involves that of the bone, and it is most commonly caused by usually it was supposedly it was just an hypothesis which has shown that it is could be an inherited disorder because of the mutation in a gene which encodes because of the mutation in a class 1 gene which encodes an alpha stimulatory gene. So this could be an inherited disorder which occurs in patients, and what we see here is radiologically it gives a ground glass appearance, which is a characteristic feature of fibrous dysplasia. And a gross specimen, it might usually involve a cancellous bone. The lesion involves a cancellous bone which is being replaced by the fibrous tissue, and this fibrous tissue can be seen which appears as gritty in appearance, and in color it gives a grey to pinkish color, and on palpation it gives a rubbery soft consistency can be appreciated. This fibrous dysplasia dysplastic lesion, it usually shows areas of hemorrhage, cyst formation, as well as certain other myxoid changes can also be appreciated. Under a microscopy we see that the normal osteoid matrix, it is usually replaced by fibrous tissue, and this fibrous tissue is arranged in the form of holes or otherwise circles. It gives a hole pattern of appearance. Other than that, we also see that the bony trabeculae, because of the abnormality in the osteoid matrix and the mineralization level, these trabeculae, they appear as abnormal shapes, giving a fish hook like appearance or otherwise a Chinese letter like pattern. So this is a histopathological picture. The first picture which shows area of a normal bone as well as an affected bone. Normal bone is which can be appreciated on the left side, that is of normal width of osteoid seams can be seen with the properly arranged trabecular arrangement, where at the right side it is probably an area of fibrous dysplasia, where we see that there's thinning of the osteoid seams, that is of the trabeculae, and they are being improperly or haphazardly arranged, giving a Chinese letter pattern. This is the second picture, the down picture, which is a high power view of the trabeculae, showing that they are interconnected, giving a Chinese letter pattern appearance. So it is characteristic, one of the microscopic characteristic feature of fibrous dysplasia. So usually fibrous dysplasia, they are clinically they can be classified into three types. Among them, monostotic type, which is a predominant type, which involves only the one particular area of bone, and it constitutes of 70% of all the fibrous dysplasias. Most commonly, it is seen affecting the age group of 20 to 30 years, and the areas involved here it could be the craniofacial region, the ribs, or the vertebrae can be affected. And these patients, they show a less characteristic, that is less severe conditions of pain or any clinical manifestations when compared to the other two types. Coming to the polyostotic type, it comprises of 25% of all the fibrous dysplasias, and usually it is, as the term itself suggests, it involves multiple bones, not only a single bone as that in the monostotic form. And most commonly here we see is involvement of the ribs, vertebrae as the craniofacial areas, and certain other long bones, femur areas can also be seen involved in polyostotic type. Coming to the third type, it is an Albright syndrome, which constitutes 5% of all the fibrous dysplasias. It is a syndrome, so it means that it not only involves the fibrous dysplastic condition, but also certain other group of symptoms can also be seen. And it is usually seen in prepubertal age, that is, the patient might manifest with precocity. Other than that, we also see certain other lesions, that is a polyostotic type of fibrous dysplasia can be seen, and certain other endocrinopathies can also be seen in these conditions. So these are three types of the three clinical patterns of fibrous dysplasia. Coming to the certain few bone tumors, these bone tumors, they could be benign bone tumors or otherwise malignant bone tumors. Among the benign bone tumors, it is the osteoma, osteoid osteoma, and osteoblastoma. Whereas in the malignant type, we can consider osteosarcoma, which is usually does not occur as such as a de novo, but rather it's a complication of certain benign tumors such as, say, Paget's disease, fibrous dysplasia, or otherwise chronic osteomyelitis, which have been discussed in the previous benign tumor slides. It could be a complications or a sequelae of these tumors turn into a malignant tumor known as osteosarcoma. Coming to osteoma, so it's a benign tumor of the bone, which is usually a slow growing tumor, and it is being regarded as an hematoma rather than a true neoplasm. That is, it is a abnormal proliferation of tissue local to its origin. So it is not a true neoplasm, and usually it involves certain flat bones, say they are the skull and the face, which are usually the flat bones of the skeletal system, and these are the most commonly involved areas for the tumor to occur. And it is a part of the Gardner syndrome. That is, Gardner syndrome, it is a syndrome usually comprised of gastrointestinal polyps, certain skin lesions, as well as certain endocrinopathies can be seen. Along with this, osteomas, multiple osteomas can also be appreciated in these patients. Radiographically, when we observe this osteoma, it gives appearance of a dense ivory-like bone mass appearance because of the increased thickening of the bone mass. It gives such an appearance. And microscopically, it gives a well-differentiated mature lamellar bone can be seen with the proper trabeculae, and these trabeculae are being separated with proper fibers as well as vascular tissue can be seen. So there is the microscopic feature and the clinical features of osteoma, one of the benign tumor of the bone. Coming to the next tumor, it is in osteoid osteoma. It is a benign tumor of the bone, most commonly seen occurring in children and the young adult age group. And usually this tumor, it is very small and it appears, and there is no patient remains asymptomatic, does not complain of any pain, but rather it's just a growth, and it most commonly seen involving the long bone, and the long bone, it is a cortex region which is involved. And radiologically, it gives an appearance of a radiolucency, which shows the presence of central needles, which is being surrounded by peripheral dense sclerotic bone can be seen. So the and histological features, that is histopathological features of an osteoid osteoma, usually shows the presence of somas osteoid numerous trabeculae, and these trabeculae show the presence of properly rimmed osteoblasts, that is showing active bone deposition. Presence of these osteoblasts give an indication that this active bone deposition being occurred, and these active bone trabeculae being lined by osteoblasts, they are being separated from the adjacent trabeculae with a proper vascularized connective tissue stroma. So the histopathological picture showing proper bony trabecular areas with numerous osteoblasts present within them, also known as osteocytes, when they are present within the osteoid matrix, and they are being separated by connective tissue stroma, which consists of blood vessels as well as certain fibers and inflammatory cells as well. Coming to osteoblastoma, osteoblastoma is very much similar histopathologically as well as radiological features. They share similar features with that of the osteoid osteoma. There's only something which distinguishes this osteoid osteoma from osteoblastoma. They are only the clinical features. And here also we see that the patients involved, most commonly the age group, it is the children and the young age adult age group, but rather here we see that the tumor, it is usually large and patient complains of painless sensation, but it is larger when compared to that of the osteoid osteoma. And most commonly involved area, they are the vertebrae, ribs, and as well as the certain long bones and ilium, which is most commonly involved in osteoblastoma. Microscopically, since they share similar features with that of the osteoid osteoma, they show similar well-developed trabeculae with the osteoblast lining, as well as these trabeculae being separated by fibrovascular stroma. So these are certain benign tumors which have been seen from the bone-forming cells. So this is a picture of the osteoblastoma showing a proper trabeculae which are lined with numerous osteoblasts, which indicate that there is active bone deposition occurring, and there is even a proper vasculature and fibrous tissue being interspersed within these trabeculae. Coming to the malignant tumor of the bone, it is the osteosarcoma. Usually we see that it is a primary malignant bone tumor which is being characterized with osteoid formation, bone formation, or otherwise both the osteoid and bone formation with not with the normal osteoblast cells, but rather they are the neoplastic cells or sarcoma cells which form this bone as well as the osteoid tissue. And usually it occurs because either it has a primary pathogenesis or the secondary pathogenesis. Primary means there's no underlying cause, but directly we can see that there's presence of osteosarcoma. Secondary means it is either, as already told, it is a progression of the benign tumors into the malignancies. That is, the benign tumors, they could be the Paget's disease, fibrous dysplasia, or otherwise chronic osteomyelitis, which might progress if untreated into an osteosarcoma. Based on the location within the bone, these osteosarcomas can be classified into two types. One is the central type or the medullary, also known as medullary osteosarcoma, or the surface type or the parosteal or the perosteal type. So these are certain types of osteosarcoma based on their location. Coming to the central or otherwise known as medullary type of osteosarcoma, we can say this is a classic type of osteosarcoma when compared to the other peripheral types, where this osteosarcoma, it is not, if not specified type, but it occurs mostly in the younger age group of 10 to 20 years of age group, where males are more commonly infected when compared to the females. And the common areas where we see the central type is, as the name itself suggests, it occurs centrally within the metaphysis region, and from there, central into the metaphysis region, this tumor can extend longitudinally into the medullary cavity or the bone marrow activity, and then from there it extends peripherally, that is laterally, adjacently to the cortex region. So this is what we see in progressing osteosarcoma to the adjacent areas within the bone. Radiologically, one of the most important characteristic feature of an osteosarcoma of central medullary type is known as sunburst appearance because of the abnormality in the bone resorption areas as well as bone deposition areas. This gives a type of sunburst type appearance, and other than that, we also see Codman's triangle is also a radiological feature. Important feature. It is known as Codman's triangle because it forms an angle between the periosteum as well as the cortex. This gives an appearance of a triangle or an angle which is formed, and this is known as Codman's triangle. Coming to the laboratory findings, usually in osteosarcoma of a central or medullary type, we find that the serum alkaline phosphatase level is raised above than the normal limit. And this osteosarcoma, since it's a malignant tumor, it shows its property of metastasis, which is a which shows it's that it's a really it is a true sarcoma or a true malignant tumor, and it's this neoplastic cells or the sarcomatous cells, they usually spread to the other areas through hematogenous route, that is through from the circulating blood levels. So this is about the central medullary osteosarcoma. So coming to the gross features, usually we find that on a gross specimen, when we when of an osteosarcoma is being seen, it usually appears grey to white in color, and the consistency, it is usually hard gritty in consistency, and certain cystic spaces can also be appreciated depending on the age of the biopsy or age of the tumor. The cystic spaces can be appreciated. The histological features of osteosarcoma of central or medullary type usually show the presence of sarcoma cells. These sarcoma cells, they are the neoplastic cells which actually lay down they lay down these osteoid matrix with an abnormal cells, and they are characterized with certain pleomorphism as well as polymorphism. That is, they may show varied range, or otherwise they might appear as varied shapes. And these shapes of the neoplastic cell, they may be spindle shape, round shape, or otherwise oval in shape. They may also show certain atypical features of presence of mitosis and altered nuclear cytoplasmic ratio. Abnormal size and shape of the nucleus or otherwise of the entire cell can also be seen. All these features of a neoplastic cell can be observed when the sarcoma cells are being observed under a light microscope and in a histological picture. The next other feature is the osteogenesis. Osteogenesis is we see that these neoplastic cells, they have a property of laying down of the osteoid matrix, or otherwise known as the bone matrix. So this bone matrix can be seen interspersed within these sarcoma cells or the neoplastic cells here in central medullary type of osteosarcoma. So these are the gross as well as histological features of osteosarcoma of central medullary type. Coming to the surface osteosarcoma, usually when compared to that of the central type, these are slow growing tumors which are seen on the bone surfaces, that is, they are being seen on the parosteal surface or the periosteal surface. Periosteal surface or otherwise known as juxtacortical osteosarcoma, it is usually seen they occur within the region of the long bones, that is in the metaphysis of the long bones. They might include among these long bones, it could include either the femur or otherwise the humerus. Suppose if it includes the femur, it includes in the lower end of the femur. Suppose it includes on in the humerus, it is the upper end of the humerus. Usually radiologically what we find, the findings here is we find a dense bony mass because of the abnormally deposited bony by the neoplastic cells. It appears as a dense radiopaque bony mass, and then a gross specimen, that is a specimen biopsy, it usually shows a lobulated circumscribed calcified mass. When it is on palpation, we see its hardened consistency and it is localized and well circumscribed area. Microscopically, what we observe of a parosteal, otherwise juxtacortical osteosarcoma, is that they show sarcomatous stroma, that is presence of numerous neoplastic cells along with the stroma, that is a connective tissue with inflammatory cell infiltrate. Other than that, we also see an abnormal bone which is being deposited by this with this neoplastic cells. These neoplastic cells do not resemble that of the osteoblasts, but rather they show varied morphologies, that is a polymorphism and pleomorphism can be seen lining these newly formed bone matrix. So this is what is about parosteal or juxtacortical osteosarcoma. Coming to the periosteal, it is usually a sarcoma or a neoplastic tumor which is being seen between the cortex as well as underlying that of the periosteum. And the most commonly involved regions, they are the diaphysis of tibia or femur. Both of them, any area can be involved. And microscopically, we can appreciate that their proper cartilaginous differentiation can be seen within these tumors. And other than that, we also see certain anaplastic tumors which is of high grade, that is, they show increased of mitotic, abnormal mitotic figures and increased in the number of figures. And other than that, we also see altered number of shapes in the cells, and alterations in the inflammatory cell region also can be seen. This is what is about surface osteosarcoma. Coming to the differences between central medullary sarcoma as well as surface peripheral osteosarcoma, or also known as surface osteosarcoma. The age group what we see here is, in central we see there it is of a younger age group, that is 10 to 20 years of age, whereas in surface it is older age group people are involved. When compared to the gender, we see that they are more commonly involved in the males, whereas in surface type there is no such sex predilection cannot be appreciated. And most commonly central type, it involves the metaphyseal region, whereas the surface type, it involves the metaphyseal as well as that of the diaphyseal region. Both of them can be involved. And coming to the pathogenesis, most commonly it is of primary pathogenesis showing genetic factors. It could be the mutations in the retinoblastoma gene or the tumor suppressor gene can also be seen. Whereas if it is involved in the secondary causes, it is most commonly a complication or a sequelae of the Paget's disease, fibrous dysplasia. And whereas in surface type, we see that the pathogenesis, most commonly it is because of it arises from the difference between the cortex region as well as from the periosteum region, we can see. And it is usually coming to the behavior of the tumor, coming to the onset of the growth. And usually surface type, we see that it is a slow growing tumor, but whereas this centrally type, it is a highly malignant tumor, that is shows an increased rate of malignancy when compared to that of the surface type. Then coming to the histological types, usually we see that it is of telangiectatic type, that is we can see dilated vascular channels which can be present in the central type, whereas that in that of the parosteal type, we see either it is a parosteal type or periosteal type. Coming to the spread and prognosis, usually it spreads with a hematogenous spread, that is by blood, and has a poor prognosis, whereas surface type, it usually spreads through, it could be prognosis to the disseminated type, and the recurrences are usually common here also. And the prognosis is usually it could be generally good or otherwise good or better for that of the periosteal type. For the parosteal type, we see that it is poorer. So these are certain differences between that of the surface type and medullary type. So this is a picture which shows, the first picture shows the histopathological feature stained under a hematoxylin and eosin stain, showing the presence of numerous sarcoma cells which can be seen, which are very much pleomorphic. That is, they show in wide variations in this variations in the size and shape of the cell. And adjacently, we can see that the bone is being deposited amongst this neoplastic cells. Then the second picture also shows that it is a highly undifferentiated tumor, which shows a varied wide range of neoplastic cells, as well as with few bony trabeculae can be seen. Other than that, few hemorrhagic areas can also be appreciated. Coming to the most commonly involved locations, here in osteosarcoma is, it most commonly involves knees, which constitutes 60% of osteosarcomas occurring in the knees. Next coming is a 15% occurs in the hip region, 10% in the shoulder region, and 8% occurs in the jaw region. Coming to the variants of osteosarcoma, it is of few variants can be seen. One is the telangiectatic variant, that is, it is an osteosarcoma. Along with the features of histopathological features, it also shows a specific dilated vascular channels can also be appreciated in this telangiectatic osteosarcoma pattern. Coming to the small cell osteosarcoma, we see the presence of numerous small cells, that is, they might either resemble the lymphomas, that is the Hodgkin's lymphoma, non-Hodgkin's lymphoma, or otherwise the Ewing's type of sarcoma can also be appreciated. So coming to the fibrohistiocytic osteosarcoma, we see that the presence of numerous fibrohistiocytic cells, and it is usually a variant or a condition of the fibrohistiocytic tumor. Coming to the anaplastic osteosarcoma, these are the sarcomas which usually occur with varied wide range of atypia can be seen. They might be poorly differentiated cells can be appreciated. Coming to the well-differentiated osteosarcoma, usually they resemble that of the mesenchymal differentiated mesenchymal stromal cells can be appreciated here in osteosarcoma well-differentiated type. Coming to the next tumor, it is the giant cell tumor or otherwise known as osteoclastoma, and it is a tumor which involves usually the long bones, that is the epiphyseal region in the long bones, and is closer to the articular cartilage, and most commonly seen it is involving the knee region in the picture as well as in the vertebrae. We can see that the lower region of the vertebrae can be involved, and other than that the other areas, they are the femur, tibia, radius and fibula, which are more commonly involved. And the age group, coming to the age group, it involves 20 to 40 years of age group, and there's no any gender predilection. They are equally distributed among the females and males. And clinical manifestations, patient might complain of pain associated with swelling. Other than that, these patients they might also show certain features of pathological fractures. Radiologically, we see there is presence of soap bubble appearance because of the abnormality seen in the bone deposition and mineralization levels. Other than that, grossly, when the biopsy specimen can be appreciated with certain hemorrhagic areas as well as certain necrotic as well as honeycomb appearance because of numerous cystic spaces, this gives that of an honeycomb appearance. Histologically, we can observe, since it's a giant cell granuloma, we can also observe certain giant cells which are multinucleated giant cells, abnormal giant cells, and other than that we also see certain stromal cells can be observed. The first picture showing the hyper view of the numerous giant cells with certain neoplastic cells and the connective tissue stroma. And there is a hyper view where we see the giant cells. They are usually abnormal in shape, that is showing wide varied morphology with presence of numerous nuclei present within the giant cells, and they are being separated with a tumor stroma, and this tumor stroma consists of the stromal cells. They could be the fibroblasts, collagenous tissue as well as the blood vessel tissue. So this is a histological feature of giant cell granuloma. Coming to the cells of origin, usually these giant cells, that is the neoplastic cells in this osteoclastoma, they can be round or otherwise spindle shaped, and they are usually mononuclear cells when we can observe, and they are known as true tumor cells. And usually they are supposed to be that they could be unfortunately originating from the circulating monocytes which fuse together with the help of the growth factor known as transforming growth factor beta, and result in the formation of giant cells known as osteoclasts. So this is the origin of the giant cells in giant cell granuloma. Other than that, we also see certain giant cells in certain other lesions, where we see giant cells in chronic chondroblastoma, that is which involves which is a tumor of cartilage, and in brown tumor, as already explained, which is a tumor of the hyperparathyroidism, and in reparative giant cell granuloma, which is another name of brown tumor, which usually regresses once the cause for the hyperparathyroidism is being removed. And other than that, we also see giant cells in aneurysmal bone cysts, simple bone cysts, and non-ossifying type of fibroma. So coming to the biological behavior of this osteoclastoma, usually it is an aggressive lesion, that is which is a rapidly growing tumor, and it can be of a malignancy. Coming to the malignancy grading, if we see, it is of a low grade tumor showing only few anaplastic cells. The recurrent state, we see that it is 40 to 60% of recurrences can be observed here in this osteoclastoma, and it shows distant metastasis. It could be by direct dissemination of the tumor cells, and it shows 4% of dissemination. And usually we see that there's this sarcoma, this giant cell tumor, or otherwise osteosarcoma, it is not de novo in arising, but rather it occurs because after the radiation of certain cancers, that is after post-radiational therapy, this sarcoma usually occurs. So Ewing sarcoma is usually Ewing sarcoma. It is a highly malignant tumor which is composed of numerous small round cells, and this small round cells can also share a histopathological features similar to that of the Hodgkin's lymphoma. So it's very important to differentiate amongst these types from the other tumors. And the most commonly involved age group, it is from 5 to 20 years, and it shows a gender predilection to males when compared to that of the females. And these small round cells, they are supposed to be, there have been many hypotheses which have been given, but there's exactly, it's of an unknown region, but there have been certain investigations which have been done and tried to know the origin for these small round cells, and they are Usually the endothelial, it could be probably of endothelial origin, or otherwise the pericytes, that is the cells which are being associated with the blood cells. They could also be from the bone marrow, or they could also be from the osteoblast origin, or from the mesenchymal cells, or the primitive mesenchymal cells from the stem cells might differentiate and result in a small round cell tumor known as Ewing sarcoma. So there are usually three variants of Ewing sarcoma. There is the classical, or otherwise known as skeletal Ewing sarcoma, and the soft tissue Ewing sarcoma, and the primitive or neuroectodermal type of tumor. So there is a picture showing the distribution of Ewing sarcoma, where we see that it's being involved either in the long bones, or otherwise in the bones are involving the leg or the hands, even in the neck part, in the ribs as well as in the vertebrae. Commonly, usually we see that these small cell tumors, they usually originate from they are of neuroectodermal origin, and they also have they share also a inherited disorder. That is, it would probably be because of the translocation of the chromosomal translocation from long arm of chromosome 11, region 2, band 4 to long arm of chromosome 22 to region 1 and band 2. So this chromosomal translocation might also induce Ewing sarcoma formation. Patients usually complain of pain, tenderness as well as fever and swelling associated with this kind of malignant tumors, and under laboratory investigations it could be appreciated that there's increase in the leukocyte count resulting in leukocytosis, and the ESR level, that is erythrocyte sedimentation level, is also being increased. And radiological findings, we see that there's onion skin appearance. This is because of the loose fibrous tissue which is being overlaid upon the bone tissue which has been formed. Coming to the gross specimen, biopsy specimen of an Ewing sarcoma usually gives a well circumscribed biopsy which is soft or otherwise friable, that is easily breakable in consistency, and the appearance, it appears grey to whitish in color. Histologically, we see that it shows a proper pattern of small type of round cells which are stained darkly basophilic in nature, and these tumor cells they're compromised within the nodules, and these nodules, they are separated with the help of properly established stroma, and this stroma shows consists of vascular tissue as well as certain fibrous tissue and collagenous tissue. Other than that, we also see certain atypical features. Since it's a sarcoma, that is, it's a malignant tumor, we see that the areas of connective tissue showing certain infiltration with new blood vessel formation, neovascularization for the tumor to grow, and otherwise we also see certain dysplastic features of atypical mitotic figures, atypical nuclear features, and atypical cytoplasmic features can also be seen. And since it's a malignant tumor, it has a property to spread, and this it usually spreads to the lungs, liver as well as certain other areas of bones and brain, and it spreads through blood, that is through hematogenous route. So this is what is about Ewing sarcoma. Coming to another bone cyst, or otherwise known as another tumor, it's an aneurysmal bone cyst. It is so-called aneurysmal bone cyst because since it shows aneurysms forming, that is dilated vascular channels can be seen, and it's also bone cyst which is being accompanied with numerous hemorrhagic areas. We see that it's usually an osteolytic kind of bone tumor which shows expanding areas of osteolytic with numerous blood-filled areas within this lesion, and most commonly involved age group, it is below the 30 years of age group, and the regions involved, they are the long bones, that is the shafts of the metaphysis of the long bones, otherwise the vertebral column can also be involved. Upon a radiological examination, we can observe that since it's an osteolytic activity, that is, bone is being destroyed, and this gives a ballooned out expansile lesion which is usually present just underneath the periosteum. So this is an osteolytic activity which gives a ballooned out appearance upon a radiograph. Patient might usually complain of pain, tenderness, and also we can observe there's a susceptibility for pathological practice in these tumors. So grossly, when we see it is, it is probably said as a sponge being immersed in the blood, since it appears as a numerous porous areas of the tissue with numerous hemorrhagic areas covering the reactive bone which is being formed by these cells. So it is known as sponge which is being immersed within the blood tissue. Histologically, what we observe is this presence of numerous giant cells can be seen. Other than that, we also see certain aneurysmal spaces which is being filled with the blood, and they are being lined by endothelium can be seen. So there is a histopathological picture of a aneurysmal bone cell where we can see numerous giant cells are being appreciated, which are usually showing various morphologies with the presence of numerous multinuclei present within the bones, these giant cells. Other than that, we also see certain other proliferating tumor cells showing presence of there's also presence of fibrous tissue known as collagenous tissue can also be seen, and these the bone cells or the giant cells, they are usually lined properly with the endothelial blood vessels, which can also be appreciated in this histopathological picture. So this is what is about aneurysmal bone cyst.